Hello everyone. I would really like to thank the AWE team for this tremendous opportunity for collaboration with the WIGNAP team, and thank you very much for the opportunity to present at this meeting today. So over the years we've used surgical options to treat many gastrointestinal disorders and conditions. However, now we have the option of using endoscopy, and in particular interventional endoscopy. And of all the conditions, achalasia is a wonderful example of how interventional endoscopy has really taken over surgical options. So really now we're reaching for the scope rather than just the scalpel. So achalasia is a primary esophageal motor disorder. Till date we don't really know what the etiology is. However, the main components are an impaired relaxation of the gastroesophageal junction or the lower esophageal sphincter, and a loss of peristalsis in the esophageal body. And over time it appears the incidence is probably growing, although this does remain a rare condition. The diagnosis is cinched up with a combination of tests. So an endoscopy will demonstrate probably salivary retention, or you may even see food and fluid in the esophagus. You will notice a very tight esophageal sphincter. A barium swallow may help show the very classic bird beak appearance, and a high resolution manometry is really needed to confirm the diagnosis, and in particular to confirm whether this patient has type 1 or 2 achalasia or type 3 or a spastic esophageal disorder. The Chicago classification system is used to help delineate the different types of esophageal motor disorders, which can be clarified with the high resolution manometry. So once the diagnosis is confirmed, there are several modalities available to help basically rupture the lower esophageal sphincter, which is the primary aim of any treatment option. So we can do a pneumatic dilatation, which is where we place under II guidance a wire across the lower esophageal sphincter, and we use a balloon to inflate and essentially rupture the lower esophageal sphincter. You can use a 30mm balloon to start with, and then if that's not effective, we often need to do 3 to 4 procedures to get an effective outcome for this patient. There is also the traditional operative approach, which is a laparoscopic helemyotomy. And when a patient does have a helemyotomy, there is a 100% risk of post-operative reflux. So all these patients also have a partial fundoplication performed as part of their procedure. And now we have evolved and developed the POEM procedure, per oral endoscopic myotomy, which is an endoscopic method of delivering a lower esophageal myotomy for these patients. So POEM is a technique where we use a regular gastroscope, place a cap on the end of this gastroscope, and create a mucosal incision in the wall of the esophagus. From there we wiggle our cap and endoscope into the submucosa. We dissect away the submucosa with a ESD knife. We use saline and methylene blue solution to help stain the fibers. We create a tunnel with this ESD type technique called submucosal dissection, and then after we've created the tunnel down to the level of the cardia past the lower esophageal sphincter, we come back and perform our myotomy, and we include several centimeters above the lower esophageal sphincter and 1 to 2 centimeters below the esophageal sphincter. Once your entire tunnel and myotomy is complete, we make sure there's no bleeding and treat any bleeding during the procedure itself, and then we close the incision with just regular endoscopic clips. The major advantage of POEM is that we can not only target the lower esophageal sphincter with this technique, but we can also perform myotomy for the entire length of the esophagus, which is required for good therapy for patients with for example, jackhammer esophagus or type 3 achalasia. And also these tunneling and myotomy techniques can be used for other conditions such as Zenker's diverticulum and esophageal diverticulum, or even gastroparesis in the form of G-POEM. So when we want to talk about the long-term outcomes of POEM, we have to actually understand the history, and actually this didn't begin all that long ago. So back in 1998, a small group of endoscopists, forward and lateral thinking endoscopists, formed a group called the Apollo Group, and you may see some familiar faces in that photograph. And one of these incredible forward thinkers was Dr. Tony Kalu, who was at Johns Hopkins for many years and also a mentor of mine, and he actually invented the whole concept of notes procedures. So what is a NOTES procedure? So if you think about the gastrointestinal lumen and you look at the serosa, which is on the outside, you've got the peritoneum or the peritoneal space. We look at the first space as the lumen of the endoscopy. We look at second space as procedures performed in that intraperitoneal space, also known as NOTES, natural orifice transluminal endoscopic procedures, endoscopic surgery, sorry. And then we've got third space. So that's when we create an artificial space, the submucosal space, which we have coined as the term of third space endoscopy. So then we must look at how did third space endoscopy evolve. So as we saw in 2004, the NOTES procedures began, and this evolved over time to third space procedures. And third space techniques were first described by J. Pasricha, who was also a mentor of mine at Johns Hopkins. And this was first performed in a swine model in an animal lab where they created a tunnel down the esophageal wall. And Dr. Pasricha discussed this with Dr. Inoue, who was a cardiothoracic surgeon in Japan, and they actually met at a conference in Adelaide where they discussed this technique, and then Professor Inoue went away and championed this procedure clinically in patients in Japan, and that's when the first seminal publication of 17 patients who underwent successful POEM procedures for achalasia was first published in 2010. So fast forward just a couple of years, and I was commencing my advanced endoscopy fellowship at Johns Hopkins, where the unit was very interested and enthusiastic about moving this POEM procedure forward. And so we had access to animal labs, and I was doing weekly animal labs to learn and perfect this tunneling technique. There were several centres across the US and Europe and Asia where people were learning and establishing the POEM procedure, and back then we used to meet at DDW every year to discuss various methods of the techniques, problem shooting, targeting any challenges, and coming up with solutions together, and sharing each other's progress together to help advance and move this technique forward and to help disseminate it worldwide. So who's actually performing these POEM procedures? If you look at that previous photo, it's actually a mixture of both physicians and surgeons. So at the end of the day, there are interventional endoscopists who are performing these procedures, and the key aspects of performing this procedure well and safely is understanding your tissue planes, separating the layers cleanly and well, understanding bleeding and how to manage bleeding. So you need both your surgical tissue plane knowledge as well as your endoscopic skills to maneuver your endoscope in such tight spaces and use your instruments and accessories very well. So let's fast forward another 5 years or so, and not only are there many published studies, both retrospective, prospective studies. There's a couple of randomized controlled trials now, but now there are guidelines being published by the various societies as to what's the best way to manage achalasia. And overall, the take-home message is that if you have type 1 or type 2 achalasia, if you have a well-trained POEM endoscopist available to you locally, then whether you have a POEM procedure or a helimyotomy, which was the traditional gold standard, you're going to have an equivalent outcome. And it really can be left up to patient preference as to which procedure they prefer to have. But it's important that in terms of your good clinical success, you've got either a physician or a surgeon who performs POEM technically very well, or a surgeon who performs laparoscopic helimyotomy very well. However, the caveat is that if you have type 3 achalasia or a spastic esophageal disorder, then POEM should be favoured, as in these conditions the mid and upper esophageal muscles also need to be targeted for myotomy. So let's look at a few studies that have actually looked at the long-term outcomes of POEM now. So this is a study looking at the efficacy of POEM in the non-achalasia group, so meaning the type 3 or spastic esophageal disorder group, and you can see that there is a significant reduction in both the dysphagia, pain and regurgitation scores in these patients. But if you look at their outcomes immediately post-procedure, so at 3 months, you can see there's very high clinical efficacy rates. And as time goes on, so looking at the the graph on the right, that's at 6-month follow-up. You can see that in the non-achalasia patients with type 3 or spastic esophageal disorders, the efficacy tends to drop over time. So really the take-home message about this is that the spastic esophageal disorder patients are unfortunately a harder group to treat, even though they do have a better clinical outcome with POEM compared to a helimyotomy. And here is another study looking at the 5-year outcomes post-POEM in all patients undergoing treatment, so all types of achalasia. And you'll see in the table on the right-hand side that the lower clinical success rates tends to be in the type 3 or spastic esophageal disorder patients. Another large study here looking at patients undergoing POEM from 2013 through to 2020, and this group looking at the predictors of recurrent symptoms and dysphagia, etc. And again, it turns out to be the same thing, that the patients with type 3 or the spastic esophageal disorders tend to do not as well as the others. The other thing that was found in the study was that the lower the post-POEM lower esophageal sphincter pressure, the higher the rate of reflux. So it's important to try to find a balance between not cutting too much and not having cut enough in terms of giving these patients relief from their dysphagia, but also not exposing them to too much volume reflux and acid reflux. So again, another large study looking at just patients with spastic esophageal disorders. And again, you look at the early clinical outcomes, and these patients are very high at 97%, and then over a 5-year period tends to decrease down to 80% or so, highlighting the same thing we saw in the earlier studies, that this is just a harder group of patients to treat. As was alluded to in the previous study, I showed that post-procedure reflux is something that needs to be monitored and can be of concern. So I think the one thing we have to bear in mind, that any treatment for achalasia which is going to relieve the patient of the tight lower esophageal sphincter and the obstruction is going to open up the sphincter, and therefore there is going to be a chance for some reflux, and this is regardless of which procedure the patient has. But we need to assess this and study this in the newer techniques, such as that of POEM. And you can see in this study, patients who had achalasia had a POEM, and if you're looking at the median 2-year follow-up, clinical success of course remains high, approaching 90%, and symptomatic reflux is in the order of 20 to 25% in these patients. I think we also need to consider reflux rates across the various ethnic groups in the population. So Caucasian population versus Asian population can be different in terms of reflux rates. This is a Japanese study assessing their long-term outcomes in terms of reflux after POEM. So if you look at the 5-year data, you can see that over time, there is a higher rate of PPI use, but we also must bear in mind that at the 5-year mark, there were quite a lot of dropouts of patients wanting to come back for follow-up, and this introduces its own bias. Are these patients not coming back because they're so well that they have no symptoms or concerns and don't want follow-up, or have they gone elsewhere and had other treatment? It's really hard to know, but on an intention to treat analysis, you have to assume the worst case scenario. So although there is a higher rate of PPI use, much fewer patients at the 5-year mark. And in those patients who did have esophagitis, whether or not they were using PPI, there appeared to be no difference between the groups. In this cohort, they also looked at the long-term course of reflux symptoms. So you can see at the 5-year mark, the rate of symptoms tended to decrease, and the efficacy of PPI also tended to increase. So over time, patients are adjusting their symptoms. Their symptoms are more tolerable, or perhaps they're responding better to PPI over time. The patients are getting used to what it feels like eating and swallowing, and their symptoms post-POEM over a certain time period. So in summary, POEM is clearly a very effective and safe treatment option for patients with achalasia. POEM and helimyotomy are equivalent and both superior to pneumatic dilatation in terms of patients with type 1 or type 2 achalasia. If your patient has a spastic esophageal disorder, then you must recommend POEM. It is far superior to helimyotomy. However, we must bear in mind that in these patients, the long-term outcomes tend to be not as good as patients with type 1 or 2 achalasia. And overall, we must remember that achalasia is a relapsing and remitting condition, and there is a risk of clinical relapse of the condition, and repeat procedures may be needed over time. In the long term, not only in terms of dysphagia do we need to monitor these patients, but reflux in particular. There is a risk of reflux. What we must bear in mind is majority of this reflux can be treated and managed very well with PPI, but there is a cancer risk in these patients from achalasia and the stasis itself, and also if there is any reflux esophagitis, then there is a risk of Barrett's progression and cancer from that perspective. So we must keep a close eye on these patients and provide regular monitoring and ongoing surveillance.